عندنا شيء؟ شندار
لا تروح ركض.
شنو تو؟ نبدأ ليه ولا نبدأ؟ عد لي 1 2 3 بعدين نبدأ. خلاص انا سوري عارف شو ندير. انا سامع شو ندير توا.
تغير الساعة.
كانت تغير حتى الدعاية تغيرت. بس اوكي لازم عندنا 60 حاجه.
شنو هذا؟ عندي بالكورونا شاب. ها؟ لازم حاطط عند لا لا تعالى ليش؟ والله يا رجل الشركه خاصه. باشمهندس قاعد يشوفهم عايز يطلع. لا لا تعالى.
باشمهندس دكتور محمد. شنو؟ الله راجع فين سريع. أبعد الناس كلها ما. دكتور محمد شنو؟ قولي 1 2 3 عاد. Good afternoon. We are apologize for this delay because of technical problem. On behalf of Libyan Thoracic Society, welcome you to this online conference of Libyan Thoracic Society. This is our first all virtual conference. The COVID-19 pandemic has forced us into work only made possible through the technology. but that is not necessarily a bad thing. I would rather see this as a unique opportunity. This conference for 2 days will give us a good chance to learn from each other in our respiratory field. I am pleased and excited to meet very expert physicians from different countries, from Qatar, from Saudi Arabia, from Egypt, Lebanon, Bulgaria, and USA. I am also thankful and grateful and thankful to Dr. Mohammed Sunusi, the Scientific Committee of Libyan Thoracic Society, and organizer committee, Dr. Isam and Dr. Hatem, to all the pharmacological company that support this conference, PharmaX, Boehringer, Viva Pharma, and Monte Pharma. I would like also thank to Dr. Mohammed Tikar for technical support from his as a technical engineer. And at the end, thankful for all the members of Libyan Thoracic Society and our guys. Thank you.
بسم الله الرحمن الرحيم، الصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. دكتور هاني الزرموح، بداية نأسف على الانقطاع أو التأخير في بداية المؤتمر زي ما أشار رئيس الجمعية دكتور حسن. نتيجة لمشكلة في توصيل الإنترنت. طيب نبدأ على بركة الله. So my presentation is on acute NIV on the world for the International Virtual Conference on Obstructive Lung Disease. So the first thing that patients see when they're exposed to an NIV mask is they're basically saying that they're not going to have this on their face. فهو بيقول لك بالليبي ان شاء الله تبين نحط هذا على وجهي. So the outline of the presentation is to look at the background, objectives, how NIV works, does it work, the pathway, and the environment, and also look at the feasibility and barriers and obstacles in our Libyan environment. And finally, we'll finish with a summary, inshallah. So the time now is 15 minutes past 4. Hopefully, I'll be finishing in 20 minutes, and then there'll be a chance to look at any questions. Unfortunately, we're not able to take comments or verbal comments. Any comments or questions, we will be appreciative if you have them on the YouTube chat comments, please. So the objectives here are to review the role of acute NIV in treating patients with acute type 2 respiratory failure, whether this is related to COPD or otherwise, and also demonstrate feasibility, prerequisites, barriers in a Libyan ward environment. So we're probably looking at HDU level or respiratory care unit level 2 care. So is this changing? ها؟ ما تغيرش عندك. ايوه. Sorry, I just need to look at my. Okay. So I think I've gone through this slide. I'll go through this slide again. So the outline is to look at the background, objectives, how it works, does it work, pathway, and the environment, feasibility and barriers and obstacles, and finish with the summary. Objectives is to review the role of acute NIV in treating patients with acute type 2 respiratory failure, and also to demonstrate feasibility, prerequisites, barriers in a Libyan ward environment. So how does NIV work? As everybody knows, the indication for NIV is acute hypercapnic respiratory failure, at least as acute treatment. The picture you see is just to demonstrate how NIV is set up. So you have the patient, usually the patient is either set up or in a position. They're usually awake, and they have this on the face connected to a ventilator. The way it works is that it reduces work breathing, relieves fatigue, recruits collapsed areas, enhances CO2 washout, and therefore improves respiratory drive. And also the renin-angiotensin system is improved in function and therefore reduces any heart failure features. Does it work? This is a very old slide from 2003. You can see in the on the yellow circle, the major breakthrough came from Paul Plant and Mark Elliott back in 2000, where they had quite a magnificent improvement in terms of mortality. And as the forest plot shows, that there is a 41% risk ratio, which is a significant mortality benefit in terms of NIV treatment. ما اعرفش شنو اللي ما يطلعش. ترى اوكي بتسمع فيها. Okay, can you hear me now? Masha. Yes, it sounds like people can hear me now. Okay, so apologies again. So we've gone through the objectives. I'm going to go through the slides, the slide of how it works, how NIV works. As I said, the indication for NIV is acute hypercapnic respiratory failure. How it works is by reducing work of breathing and relieving fatigue. It also recruits collapsed areas, enhances CO2 washout, and therefore improves respiratory drive, and also improves the renin-angiotensin system, and therefore relieving the heart failure features. The picture here is of a conscious lady who's semi-recumbent with the mask on the face, obviously connected to the BiPAP machine. The next slide is to show just one slide to go through the previous evidence. Obviously, this is a very old forest plot from 2003, but it does show the mortality benefit to be very clear with regards to NIV being superior to previously identified usual medical care. If we look at the yellow circle, going back to the Paul Plant study, there was a clear benefit in terms of mortality. The overall risk ratio is 41%, which is quite significant finding. So NIV for a number of years now has become the standard of care. It's the standard of care as far as NICE is concerned, the Royal College of Physicians, British Thoracic Society, Intensive Care Society, European Society, American Society. So this is a worldwide accepted standard of treatment for patients with acute decompensated type 2 respiratory failure. NIV is obviously contraindicated in some patients. So the reason I put the slide, I will not be going through all the contraindications, but this is the message here from the slide is to demonstrate that NIV is not for everybody. Pathway for NIV. This is quite an important slide, and unfortunately, we do not practice this in Libya. The pathway for NIV is that it needs to be quite robust. Patients need to have frequent arterial blood gas measurements, and if this is not available, then the service for NIV provision is not going to be sufficient. So if we go through the top of the screen, the top box says patients with acute exacerbation of COPD, they undergo an assessment by the admitting doctor, whether this is in a medical ward or an emergency department. They are also, they are given an arterial blood gas, and this shows type 2 respiratory failure with decompensation and respiratory acidosis. The management plan for these patients is that they are given controlled oxygen therapy with target saturations of 88 to 92%. They're also given continuous bronchodilators through a nebulizer. They're given steroids, intravenous or oral, depending on the patient, as long as they are systemic, and also antibiotics if they're indicated. And this is for the first 1 hour. So the first 1 hour is quite critical in terms of providing treatment and hurrying up with the treatment. After 1 hour, the patient's given another ABG, and the pH is assessed. If the pH is just less than 7.35, then the patient will require an NIV. The severity of the second ABG or the second reading of the pH determines the likelihood of them either being successful or failing with an IV and therefore requiring endotracheal intubation. So, for example, the box on the far left side, if the pH on the second ABG is less than 7.2, then yes, you should try NIV, although the patient is very acidotic, you should try NIV, but also bear in mind that there is a 50% chance that the patient will require intubation. But if the pH is just less than 7.35, then of course NIV is indicated, but there's a very, very high chance that the patient when looking at NIV, there's obviously a number of rules that people have to abide by. These are all based on basic good medical practice. So the first point I have here is to do with documentation. So the NIV decision needs to be documented very clearly. Prescription of NIV, so you can't just give a verbal order, start NIV. It needs to be, because it's a form of treatment, so it needs to be prescribed. And there's also documented decisions about sealing of treatment. Setup is very important. A full face mask here, as in the picture, is the preferable option. In Libya, we don't have many face masks or full face masks. Many of the masks used here in Libya are oronasal face masks, which would also be sufficient, but I guess slightly inferior. The way to do it is to initially set the patient up on an IPAP of 10 centimeters of water with an EPAP of 5. You can try 8/5, but most people will tolerate 10/5 to start with. But the poor practice is when patients are left for hours and hours and hours on 10/5. This is not going to be sufficient to provide good ventilation. So the advice here is that the inspiratory pressure, or the IPAP, is increased by 2 to 5 centimeters increments every 10 minutes. In other words, you can increase the IPAP pressure by 5 centimeters of water every 10 minutes or 15 minutes, as long as the patient is tolerating. Your target IPAP is 20. If the patient is tolerating more, you can go up to 25, but there's been other papers where they found that aggressive NIV does not improve outcomes. Along with that, many or most patients will require oxygen. If they require oxygen, then the important thing is that they are controlled oxygen. They have controlled oxygen with target sats of 88 to 92. Nebulizers during breaks, if possible. If nebulizers are not tolerated during breaks, in other words, the patient becomes blue or not able to breathe during a break, then the nebulizer can be administered through a T-piece. The next slide, in terms of monitoring, patients need to be monitored very closely with a continuous pulse oximeter and an ECG monitor. Repeat ABGs, extremely important. If we look back at the previous, pathway, we said that there's an initial ABG. This will be followed by the second ABG, and then a decision will be made to start patients on NIV. A repeat ABG again, which is a third ABG, needs to be taken 1 hour after 1 hour of NIV therapy. So once you've started an IV, a repeat ABG needs to be taken. And also 1 hour after every subsequent change in settings. Every time you change settings, you have to do another ABG. And also after 4 hours or earlier in patients who are not improving clinically. So if the patient's not improving, then you have to keep an eye on the ABGs. You have the option of either sticking in or putting in an arterial line, or just repeatedly stabbing the patient. So there is both options. Agitation is very frequently seen in patients who require an IV. There's two options. You can either use opioids or benzodiazepines that put in some doses and routes. You can use the IV or the subcutaneous route. So for morphine, you can use 1 to 2.5 milligrams under close supervision. For midazolam, it's a very similar dose, but also this needs to be done with good expertise in terms of how to recognize and manage patients with overdoses of benzos and opioids. Escalation of treatment also needs to be decided and documented. What are the maximum pressures? What's the intubation plan? If the patient is for intubation or not, and what's the CPR decisions. Weaning also needs to be looked at when somebody is thinking of putting patients on NIV, and also palliation of NIV or on NIV. Unfortunately, we don't have much time to go through weaning and palliation options, but I've put this slide. So this is a paper by Senegolo in 2010, looking at patients who received an opioid, and also looking at patients who received midazolam, benzodiazepine. So as you can see from the top graph is that a few hours after administering the benzo and the opioid, you can see that the CO2 has come down in terms of which indicates that CO2 does come down if given in small doses and also under monitored environments. The respiratory rate is also nicely improved along with the next few hours, this is demonstrated in the graph below. So this slide just demonstrates that you can and you should use anxiolytics and opioids in patients who are agitated when treating them with acute NIV. Coming to the end, the environment, this is extremely important. NICE in the UK says that that level 2 care or ward care with enhanced provisions beyond general medical ward is what NICE says, but practice really varies from country to country. I'm not sure if the slide reads well, but this is a paper from Mark Elliott back in 2002 where they've conducted their initial cornerstone RCT in 2000. So they've published this paper to look at the options and factors considered when looking at where is the best place to have NIV. So the factors to be considered is location of staff and training and expertise in non-invasive positive pressure ventilation, and also if you have a number of staff that are well trained, then they have to be available 24/7. So you can't just have well-trained staff in the morning hours, and then over the nights and weekends, you will have the less trained staff because NIV patients have to have staff available for them with the right expertise throughout the day. And also another factor to look at is the rapid access to endotracheal intubation and invasive mechanical ventilation. So this is very important because any patient on an IV might deteriorate further and require intubation and ICU. Coming to reality in terms of feasibility, أو الجدوى, barriers and obstacles. So the first thing that comes to mind when looking at acute NIV is doctors training and convincing. Many medical doctors will not be convinced that they can treat patients with acute NIV or on a high dependency unit or especially on a ward. But I think it does indicate that there is lack of training, perhaps problems with convincing, but this is all coupled with lack of nursing
How many professionals are necessary to make more than 100 crucial decisions daily? How many scientists are necessary to develop more than 500 new scientific researches? How many experts are necessary to develop and train new talents joining our company day after day? How many qualified people are necessary to ensure the quality and safety of more than 300,000 boxes of medicine produced every day? We are thousands of employees who understand the criticalness and necessity of medicine in your life and in the lives of your dear ones. Our objective, contributing to the health and well-being of 400 million Middle Easterners, 700 million Africans. Eva Pharma, securing your health.
أهلاً بك في الفيديو التعليمي القصير الذي سيعرض لك الطريقة الصحيحة لاستخدام جهاز فلوتيفورم HDI الخاص بك. ربما كان طبيبك أو الممرضة أو الصيدلاني بالفعل قد عرض لك كيفية استخدام الجهاز والاعتناء به، ويقدم هذا الفيديو تذكرة لك. لذا فمن المهم أن تحرص على اتباع هذه التعليمات لضمان إعداد دوائك الإعداد الصحيح، وأن يصل إلى رئتيك عند استنشاقه لتحقيق العلاج الفعال لإصابتك بالربو. التعرف على جهاز HDI الجديد. يتكون جهاز فلوتيفورم HDI من مكونات متعددة. يأتي هذا الدواء في عبوة بخاخ توجد داخل غلاف من البلاستيك يسمى مشغلاً، ويحتوي الجهاز على قطعة فموية، ويوجد أيضاً غطاء للقطعة الفموية والذي ينبغي وضعه في حالة عدم استخدامك للجهاز. يوجد أيضاً عداد داخلي للجرعات يشير إلى عدد النفخات المتبقية، ويحتوي الجهاز على 120 نفخة عند الاستخدام، مما يعني وجود علاج كاف في كل جهاز يصلح للاستخدام مدة 30 يوماً. سوف يعد المؤشر عداً تنازلياً كل 10 نفخات بدءاً من 120 إلى 60، ثم يبدأ عداً تنازلياً جديداً كل 5 نفخات إذا تبقى أقل من 60 نفخة. تعني الخلفية الخضراء الموجودة على المؤشر وجود ما بين 120 و 50 نفخة متبقية، وبمجرد تبقي 50 نفخة سوف يبدأ مؤشر الجرعة إلى التحول للون الأصفر، وعندما يبدأ المؤشر في التحول إلى اللون الأحمر فهذا يعني وجود 30 نفخة متبقية أو أقل، وهذا سوف يتطلب استخدام جهاز HDI قريباً. ولا تستمر في استخدام الجهاز عندما تأتي قراءة المؤشر عند الرقم 0 حتى إذا ظهر الجهاز كأحد تفضيلات وصفات الطبيب. ينبغي تخزين الجهاز في درجة الحرارة العادية للغرفة. قبل استخدامك لجهاز HDI للمرة الأولى، سوف يعرض لك هذا الجزء من الفيديو كيفية تجهيز فلوتيفورم HDI الخاص بك وتحضيره للمرة الأولى، أو إذا لم يستخدم الجهاز لمدة 3 أيام أو أكثر. لتحضير الجهاز، يرجى إزالة غطاء القطعة الفموية، ثم رج الجهاز جيداً. يرجى إزالة القطعة الفموية بعيداً عنك، ثم الضغط على علبة البخاخ لإطلاق نفخة واحدة، والذي يعرف أيضاً باسم تشغيل الدواء. كرر خطوة التحضير 4 مرات في المجمل، وتذكر أنه ينبغي الحرص دائماً على رج جهازك قبل كل نفخة فوراً، وهذا لضمان مزج الدواء بصورة ملائمة، وأن الدواء قد أصبح جاهزاً للاستنشاق. بعد تحضيرك جهازك، أصبح الآن جاهزاً للاستخدام. إذا تعرض جهازك إلى درجة حرارة التجميد فيجب تحضيره أيضاً قبل استخدامه مجدداً، وفي هذه الحالة يجب ترك الجهاز ليدفأ في درجة حرارة الغرفة لمدة 30 دقيقة، ثم يجب تحضيره كما هو مبين أعلاه لضمان عمل الجهاز على نحو مناسب. كيفية استخدام جهاز فلوتيفورم HDI. سوف يعرض لك هذا الجزء من الفيديو كيفية استخدام جهاز فلوتيفورم HDI على نحو مناسب لضمان تلقيك الجرعة الصحيحة للدواء. أولاً، يرجى إزالة غطاء القطعة الفموية، ثم تأكد من نظافة القطعة الفموية للجهاز وخلوها من الأتربة. وينبغي رج الجهاز قبل كل نفخة فوراً. ولاستخدام الجهاز ينبغي وضعه في وضع مستقيم أو الوقوف. أخرج زفيرك بقدر ما يناسبك. أمسك الجهاز في وضع مستقيم باستخدام إصبع الإبهام على قاعدة القطعة الفموية وإصبع السبابة أو بأعلى علبة البخاخ. ضع القطعة الفموية على فمك ما بين أسنانك وضع شفتيك حولها. ولا تعض القطعة الفموية. تنفس ببطء وبعمق عن طريق فمك، وبعد البدء في التنفس اضغط على علبة البخاخ لإخراج النفخة الأولى، واستمر في التنفس بثبات وبعمق، ثم احبس نفسك بقدر ما يناسبك، ويفضل ما يقرب من 10 ثوان. في النهاية، يرجى إزالة الجهاز من فمك وإخراج الزفير ببطء، ولا تخرج زفيرك إلى داخل الجهاز. وللحصول على النفخة الثانية يرجى الانتظار مدة 30 ثانية، ثم تكرار العملية بدءاً من رج الجهاز، ثم استنشاق الدواء، ثم حبس النفس، ووصولاً إلى إخراج الزفير. فهذا سيساعدك على ضمان حصولك على أقصى استفادة من الدواء. وتذكر رج الجهاز قبل كل نفخة فوراً. يرجى استبدال غطاء القطعة الفموية بمجرد أخذك لجرعة الدواء، وتذكر أن الجرعة المعتادة هي استنشاقان مرتين يومياً، أي مرتين في الصباح ومرتين في المساء، وهذا إذا أردت الحصول على الجرعة اللازمة التي وصفت لك لمرض الربو. بعد استخدامك للجهاز، مثل أغلب أدوية الربو التي تؤخذ عن طريق الاستنشاق، ينبغي شطف فمك بالمياه، ثم بصق المياه المتبقية أو غسل أسنانك بالفرشاة، فهذا قد يساعدك على تجنب الإصابة بقرحة الفم والحلق أو حدوث تغيرات بالصوت. إرشادات ونصائح عند استخدام جهاز HDI. يعلم الكثير من الأشخاص المصابين بالربو فائدة وجود جهاز HDI بالقرب من فرشاة أسنانهم، فهذا سوف يساعدهم على تذكر أخذهم للعلاج كل صباح ومساء. وقد تجد من المفيد التدرب على تنظيم النفس البطيء والعميق والضغط على علبة أمام المرآة. ربما يرى البعض أن من الأيسر مسك الجهاز بكلتا اليدين، عندئذ ينبغي وضع إصبع الإبهام في كلتا اليدين على علبة البخاخ، وإصبع السبابة في كلتا اليدين أسفل قاعدة القطعة الفموية. وينبغي التنفس ببطء وبعمق عند استخدام جهاز فلوتيفورم HDI. وتكمن إحدى النصائح لمساعدتك في التنفس ببطء إذا كان بالقدر المناسب في التنفس أكثر من 5 ثوان. لذا ينبغي لك أن تضغط على العلبة لإخراج الدواء مرة واحدة مع كل استنشاق. إذا رأيت رذاذاً من أعلى الجهاز أو من فمك، فربما لم تستنشق الدواء الاستنشاق المناسب. لذا ينبغي أخذ جرعة أخرى عن طريق تكرار التعليمات المبينة في وقت سابق في هذا الفيديو. إذا واجهتك صعوبة في استخدام الجهاز، فقد ينصحك طبيبك أيضاً بما يسمى بأداة مباعدة، وذلك لمساعدتك على أخذ العلاج بصورة مناسبة. وسوف تأتي الأداة المباعدة مزودة بالتعليمات الخاصة بالاستخدام المهم به، وسوف ينصحك طبيبك أو الممرضة أو الصيدلاني بشأن كيفية استخدام هذه الأداة المباعدة مع جهاز HDI. الاعتناء بجهاز HDI. يرجى عدم إزالة علبة البخاخ من الجهاز، ومن المهم تنظيف جهازك كل أسبوع. ولتنظيف الجهاز ينبغي إزالة غطاء القطعة الفموية ومسح الجزء الداخلي والخارجي من القطعة، ثم الجزء الخارجي من الجهاز بقطعة قماش نظيفة وجافة أو منديل. ويرجى استبدال غطاء القطعة الفموية. شكراً على المشاهدة.
Ladies and gentlemen, thank you for all efforts from the Libyan Trust Society for this international
conference. I will be present allergy and asthma immunotherapy.